to the introduction, and I'm very happy to be invited to speak to you today. Yes, indeed, unfortunately not live, but still I'm happy to be part of this virtual meeting. So you mentioned already my topic. It is about the clinical practice and whether or not we are able to differentiate between the typical axial spondyloarthritis or the patients who suffer from inflammatory nature of back pain and symptoms of inflammatory nature as well, although they have primarily psoriatic arthritis. And you will see that there might be some solutions and some suggestions, but there is still a lot of question marks that we have. Now, while going through the slides, there might be some older slides also from the what we call typical or pure axial disease. But I think it is nice to start this kind of presentation by reminding you what we call axial disease. And axial disease, independent of the nature of it, is, at least for us in rheumatology, meaning that we have not only pain, not only back pain, but we have involvement of the entire spine, which leads later on to the loss of the lordosis and slight hyperkyphosis in the midterm, and in the long term, things that we do not see anymore, the real hyperkyphosis, where patients are severely affected. And of course, with axial disease, we do not only mean the spine, we also mean the area of the sacroiliac joints. Many people also think that the root joints, such as the hips, are also belonging to the axial skeleton. Now, I'm not going to lose too much time on propaedutics, but nevertheless, I would like to remind you that we have not even solved the fact that we don't know the real prevalence of patients suffering from pure axial disease like ankylosing spondylitis, because we have so different data and different information from different parts of the world regarding their prevalence. This is just one attempt which has been published many years ago to summarize the data, and I have to say that we do not even know exactly what axial or how frequently axial disease occurs with or without psoriatic arthritis or axial spondyloarthritis, although again there are now more and more data coming out. What we do know nevertheless is that there is a peak in the age of presentation of the diseases such as ankylosing spondylitis or axial spondyloarthritis and psoriatic arthritis here. Yes, axial spondyloarthritis may occur much earlier. However, we are aiming towards earlier diagnosis in all rheumatic diseases, and I think that these peaks may indeed also shift a little bit to closer time points during the life of the patients, and obviously these differences may not be there in a couple of years from now. Now, looking at the entire spectrum of spondyloarthritis, I think it's pretty well known to everyone that we have the separation between axial and peripheral. In the peripheral spondyloarthritis, we do not have to, but we can add psoriatic arthritis, or we can see it as a completely different disease and entity. And indeed, in those patients with psoriatic arthritis, you also know very well the GRAPPA domains that I will show you later in another slide. Axial disease is one part of that. So we see that indeed the borders are really flowing into each other, and I believe there's no clear decision of what peripheral and axial spondyloarthritis may be, because there's no distinct entity. There might be patients with mainly peripheral spondyloarthritis where they suffer from axial disease. We just don't ask them, for example, about these symptoms. And these are things that we need to keep in mind when I present you the data hereafter. Now, in order to classify, not to diagnose, but at least to classify patients in the different spondyloarthritis areas, we of course know very well the classification criteria that are there. I'm mentioning here the classification criteria for axial spondyloarthritis, where we also do have psoriasis, and of course we do have arthritis, and I would sum those two into psoriatic arthritis phenotypes with mainly back pain. So overall, I want to mention by this slide that we do not still lacking classification criteria for axial PSA. There is a combined effort from ASAS and GRAPPA to develop this criteria right now, and I guess in a couple of years we will be able to maybe summarize all the symptoms of these patients that we believe have pieces of both axial axial SPA and PSA in one classification criteria set, but we are not there yet. Again, I mentioned, and I'm really going a little bit faster over those things because some of them are repetition indeed. I would like to remind you that PSA is not just peripheral arthritis, it's not just axial disease. Of course, it's also dactylitis, skin disease, and enthesitis maybe as well here, and also nail involvement, where we will see all these domains, how they come up or sum up to one disease which might also be predictive for or against axial involvement. Now, going into, there is an animation here that did not come through. Going into the criteria that we have available, I mentioned that already, especially when we want to have some very, let's say, clear evidence or clear picture of what axial involvement, not axial disease, but axial involvement is. We do not only rely on the clinical symptoms that we have, for example, for inflammatory back pain, but we also look at images, especially X-rays are important here, because once you've seen these typical X-ray changes with erosion, sclerosis, and possibly also ankylosis, then you're pretty sure that these patients have had inflammatory activity that developed into new bone formation. Nevertheless, we want to see patients earlier than when they have these kind of changes. It's like in rheumatoid arthritis, we would be waiting, the old example, we would be waiting for erosions to have the diagnosis. And this is why we need to understand a little bit better what is happening in patients with psoriatic arthritis who may suffer from inflammatory back pain. Now, the problem gets a little bit more difficult and more complicated, because unfortunately also in the field of psoriatic arthritis, there is no clear evidence of how frequently we would be seeing axial involvement in these patients. There are different data sets that has been well put together in this overview, in this article that was published a couple of years ago. And there we have seen or have learned that indeed, based on the study that you will be getting in, as a reference, you may see prevalences of 5% or up to 70%, most probably based on how long the patients have been having psoriatic arthritis. So, of course, it's trivial, but we need to understand this also for interpreting the results. The longer the psoriatic arthritis occurs, the more probable it is that patients will also suffer from inflammatory findings or inflammatory symptoms of back pain. Now, of course, the question is it because the disease evolves and goes further up to the axial skeleton? Or is it because the patients stay longer with the rheumatologist, and at some point the rheumatologist asks them about inflammatory back pain? I cannot answer this question. Nevertheless, we see that indeed there is a huge difference and a huge, let's say, gap or range, better said, a huge range between the prevalences, most probably also being associated with the duration of psoriatic arthritis. And one important information that I would like to give you at the end of this, let's say, summary, is that independent of the classification criteria you may be using, either the modified New York criteria or the CASPA criteria, if you apply this criteria to a set of patients who have a diagnosis of ankylosing spondylitis or have a diagnosis of psoriatic arthritis, you will see that, yes, of course, all of them may also fulfill the classification criteria of New York, but every fourth will also be able to be classified as having psoriatic arthritis, and vice versa. In those patients who have psoriatic arthritis, every fourth may also be classified as ankylosing spondylitis. This means in about 50%, if you add those together, in about 50% of our patients, if you take the whole spondyloarthritis spectrum, there might be some dissociation, or let's say some confusion, and which is again emphasizing the fact that we need clear classification criteria for the entity that we call axial PSA. Now, going into more clinical evidence and information, we would like to see who are the patients who are in this kind of gray phenotype, which may be called axial PSA. and we would be starting with a genetic background. And from what we've seen is that based on the risk factors for both of the diseases, the only genetic parameter that has been found to be overlapping and being common in those of them is HLA-B27. Of course, you can say that you can take B27 plus ERAP1, for example, to get closer to ankylosing spondylitis, or B27 with any of the other genetic factors to get closer to psoriatic arthritis with axial involvement. But nevertheless, we don't do that in daily practice. In daily practice, we do B27 testing, and if this is positive, this doesn't tell you whether or not the patient has more the axial disease or more the peripheral disease with axial symptoms. So we do not get a clear answer from that parameter. However, what we do get from B27 is the fact that those patients who are B27 positive, either they are psoriatic arthritis primarily diagnosed or primarily diagnosed for ankylosing spondylitis, if they are B27 positive, they develop much more severe radiographic damage over time as compared to the same disease with B27 negativity. So B27 may not be a diagnostic factor, but most probably, based on this data, a severity factor for both parts of the disease. We nevertheless can rely on clinical symptoms and clinical findings, and you see here I'm showing you older data reporting risk factors for axial involvement in patients primarily diagnosed with PSA. And those clinical risk factors are the severity of the disease based on the number of swollen joints, including psoriatic nail dystrophy, and also the radiographic damage, which of course goes together. This means the number of affected joints and those who have certainly new bone formation in the peripheral joints. This means periostitis. This is shown in both the univariate analysis and the multivariate analysis, taking into account all the other parameters, and of course the inflammatory markers like ESR, I would add CRP here, are also playing a role. So the patients who are more severely affected, that's what I take from this slide. This means have more swollen joints and also have nail dystrophy, and obviously will also have structural damage in their peripheral joints. They are the ones who most probably later will develop axial disease as well. In that study, again, 15% have developed axial psoriatic arthritis, but I've shown you already that this may differ from study to study, and the range is very large. There's also other data which I believe are extremely interesting, showing whether or not you would be able to identify axial psoriatic arthritis only by the clinical symptoms or by adding imaging even in patients who do not complain about axial disease. And what we have seen in this, again, very interesting study is that at least those four parameters in the upper part of the slide are important. Female gender seems to be actually underrepresented clinically, but if you do an X-ray or an MRI, more frequently you will find inflammatory findings. So females seem to be underrepresenting their axial symptoms. The biologic DMARD, I take this as a proxy of the physician thinking that the patient is severely affected. Yes, obviously the overall clinical symptoms are leading to the physician to escalate the treatment with biologic, and this overall very severe clinical picture may be associated also with axial PSA, although obviously the patients were not reporting axial symptoms. And similarly to what I showed you before, the tender joint count and the swollen joint count, there might be even more patients who may be diagnosed for axial psoriatic arthritis if we would be doing imaging, which means again that even this swollen joint count that I mentioned before may be underrepresented. Doing additional imaging in the axial skeleton may reveal even more patients with axial PSA, summarizing that the overall picture that we see as physicians may be, I call it now, dangerous in terms of having patients not only with peripheral symptoms but also axial disease. But on the other hand, the patients do not, especially the females, do not complain much, unfortunately, in order to make us aware of axial symptomatology, and the number of tender and swollen joint may not even be enough we would be needing, especially if we see many swollen joints being affected, we would be needing also additional axial imaging, even if the patients do not primarily report back pain, because you see here those p-values are significant in terms of underdiagnosis. And this, in fact, may be summarized in this slide that I am quoting from the last EULAR Congress, where patients from the Corona Registry were given questionnaires about asking about many things, and also about axial symptoms. And you see the title of that abstract, which is I've also taken as a title of the slide, that indeed there is a higher number of patients with elevated spine symptoms as compared to what the investigator would have said. So we need to be aware that the patients that we are having in front of us with psoriatic arthritis may be suffering from axial symptoms. I include here inflammatory back pain, but obviously we're not asking them that frequently about that, or they are not reporting it because they think they come for their hands and their feet to the doctor, but back pain may be something that they do not even imagine to go to the rheumatologist for. So I just want to make you aware, please ask for inflammatory back pain and additional findings. And the reasons to have axial involvement as compared to those who did not have axial involvement are shown here. So obviously there have been patients who have been B27 positive. I mentioned that already. This is something that we have in common between axial involvement and peripheral involvement. Well, the colleagues from the US also have tried to find other factors that may be associated with or without axial involvement. You see here those PSA patients with axial involvement also showed higher depression rates. I call it now maybe because of secondary fibromyalgia or other reasons that may be there because of the severe pain that they are suffering of. And biologic use is what I call a proxy for disease severity. Obviously, the more severe patients, you will give more biologics. That's what they have found. And other concomitant therapies were also taken into account. I just mentioned these kind of things, although I'm not going into details here because I believe it's just secondary information. Now, looking at the clinical part beyond the genetic part and the prediction factors, I would like to remind you that we also do not have any, I would call it any sufficient or any adapted manifestations or clinical manifestation criteria for axial PSA. We're still using, and I mentioned this before, we're still using the inflammatory back pain criteria and transfer them from the axial spondyloarthritis to maybe axial PSA. One of the parameters to identify inflammatory back pain are the ASAS criteria that I believe every one of you is aware of. And in fact, this is what we would call identification of inflammatory back pain independent of the primary diagnosis. We of course can make also use of imaging, and we know that especially in those patients with typical axial spondyloarthritis without psoriasis, there is a more symmetric involvement of the affection of the sacroiliac joints. In patients with axial psoriatic arthritis, we may have more unilateral asymmetric involvement of the sacroiliac joints, still with severe erosions and partly ankylosis of the affected sacroiliac joints. And this is something we've also found in a very recent small publication, nevertheless, where we had patients with axial spondyloarthritis without PSA, and when we checked their MRIs, we found bilateral inflammatory involvement as compared to those who had psoriatic arthritis and had axial involvement. And they also indeed developed, or let's say in the majority, numerically seen, had unilateral inflammatory lesions. And if we look at these inflammatory lesions in patients with psoriatic arthritis when they have sacroiliitis on the MRI, it has been well shown years ago from the colleagues from Leeds that biopsies from that area show exactly what we know also from biopsies from the peripheral joints. So indeed there is this enthesetic pattern that we know from the dactylitis and the enthesitis in the hands, where that we would also identify in patients with sacroiliitis in psoriasis primarily diagnosis. Other information that I believe is also of interest is the comparison of the MRI images of the whole body MRI examinations. Here you see psoriatic arthritis patients. In the lower part, you see spondyloarthritis patients. The colleagues from Norway checked for synovitis, bone marrow edema, erosions, peripheral involvement, axial involvement, spine, sacroiliac joints. And what they found was that, yes, there might be differences in the distribution of the lesions, in the severity of the lesions, but the distribution is pretty similar, which means that on an MRI, you cannot just identify what it is. You need the clinics in combination with the imaging to find out what the primary diagnosis may be. And maybe there's no primary diagnosis. You have to say that we have spondyloarthritis with peripheral involvement, obviously, and psoriasis. Now, another thing that caught my attention and was published really recently is the reasons to maybe identify patients as early as possible. And what the colleagues from Berlin in Germany did in that study was to check patients with axial spondyloarthritis primarily and see how the diagnostic delay has developed over time. And you see here that we still have a gap of about 7 years, 6 to 7 years from first symptoms to the diagnosis. We remember it was about 10 years, in the late 90s. And I draw your attention on panel D, among all other findings that would lead the patient to the rheumatologist. And it was shown that if the patient has or does not have psoriasis, this did not shorten the time point of diagnosis. It was a different thing with B27. The B27 patients went earlier to the rheumatologist. The males went earlier to the rheumatologist, but psoriasis did not do that, which is a little bit of a surprise to me, because I would have thought that if you have psoriasis and you also have arthritis, the dermatologist would send the patients to the rheumatologist, but this, at least in Germany, does not seem to be the case. I don't know what the reasons for that are, but still we are lacking a lot of information to transmit to our colleagues in order to send us the patients. And obviously, if they would be sent as psoriatic arthritis patients, we could ask the questions about back pain and identify axial PSA as well. Now, looking at a possible way of doing so and communicating to the general practitioners, I'm pretty sure you've seen this slide by me many times before, but I'd like to bring it back in the context of today's presentations, reminding you that what we are doing in our practice today is to have patients who are young and are complaining about buttock pain. If you add psoriasis as the main objective factor of skin disease, obviously, and you two of the three symptoms from the patients will be positive, then it makes sense to send them to the rheumatologist. And B27 as a common factor, again, of axial PSA / axial spondyloarthritis, B27 can only or should only be done if one or less than one of those three factors are positive, but the patient still suffers from chronic back pain. And you see that indeed the sensitivity and specificity by adding psoriasis is pretty high. Now, the next question is, how do I capture these patients? How can I assess them in daily practice for their disease activity? And unfortunately, we do not have one simple or single assessment or questionnaire that assesses all domains of psoriatic arthritis, including axial disease. That does nothing to be bad at all. I mean, we also want things to be feasible, but nevertheless, you see that axial disease may be left out in the vast majority of those questionnaires. This is maybe why we have not been able to identify patients with axial disease that frequently in the past, simply because most of those questionnaires in the studies being used before have not captured axial disease. And the same is, of course, true for the asthmas and the basti, which are the domains that we're using in axial spondyloarthritis. We do not include psoriasis, obviously. We do include peripheral pain in both, but obviously fatigue and tenderness that are important for PSA are not being captured by ASDAS. On the other hand, of course, ASDAS has the patient's global assessment that I showed you is also associated with later development of axial disease. So still here, we don't have the best out of both worlds, but we're trying to combine as much information as possible. Now, going over to treatment, I like showing this older slide because it pretty well captures what is happening. We know that we have a trigger in any of those diseases, PSA or axial spondyloarthritis. We know that this trigger, whatever that is, would obviously via the genetic factors initiate the inflammatory cascade. IL-23 is playing a role, the T cell is playing a role, IL-17 is playing a role, TNF is playing a role. However, we know that although both diseases are enthesetic in nature, not all of those targets are working in both diseases. For example, IL-23 will not work in axial disease at all. IL-17 will work in both. TNF inhibition will also work in both. And we've seen, and you see the data later on, that maybe IL-23 and IL-17 may be working in axial PSA, although they are not working in axial spondyloarthritis. So we need to learn also a little bit more about the pathogenesis of these diseases. We also know from older studies that if you have IL-23 found in the entheses, and which is correlating with IL-17, and you give an IL-17 inhibitor, the enthesitis and extent and severity will significantly improve. So there seems to be a rationale there to use this pathway, either IL-23 or IL-17, in patients with primarily psoriatic arthritis. Looking at what or how we treat our patients, very brief overview. As a reminder, axial spondyloarthritis, we have not many choices, either NSAIDs or biologics. In biologics, I mean TNF blockers and IL-17 inhibitors. The GAPA scheme, also well known, having the axial disease information borrowed by the ASA's EULAR recommendations. However, peripheral arthritis may involve also other compounds like IL-23 inhibitors here, or maybe PD4 inhibitors, which nevertheless are not being used so frequently. And the EULAR recommendations are also saying that if you have primarily axial disease, TNF blockers and IL-17 inhibitors should be, EULAR recommendations for PSA, should be primarily used. We did not include IL-23 here yet. This is something that may come in the next version. How do these drugs work in daily practice? Well, we again take the experience from spondyloarthritis. 40 to 50% of the patients will respond to TNF blockers when they have primarily axial SPA. Similar data we've seen with secukinumab, and I would also add here ixekizumab as IL-17 inhibitors, not only in the short but also in the long term. And the interesting data come now more and more from studies that are primarily dealing with axial PSA as the entity, as an own entity. In the maximized trial with secukinumab, we took patients with PSA and diagnosed with PSA, fulfilling the CASPA criteria, but also having high BASTA, having high levels of back pain, and where the physician said there is in PSA also axial involvement. And you see here the colored lines. We've seen a significant improvement as compared to placebo, and those who were on placebo, when they were switched to active drug, they also improved similarly. So this is ASAS 20/1 here, and you see 80% have responded very well. So I guess that's one proof of the context that indeed, or of the whole project Axial PSA, that indeed shows that the drugs are useful and the patients are suffering from axial disease, since their axial pain seems to be improving significantly. This was IL-17. If you take IL-23, you will see similar data. This is just a short snapshot of the data presented at EULAR. The manuscript is full of data, of course, and here you also see with guselkumab, the IL-23 inhibitor, significant improvement in BASTA, spinal pain, modified BASTA without the peripheral involvement, and ASDAS, all of them were significantly improving as compared to placebo. So this left part of the slide that I showed you before seems to be working pretty nicely in patients with PSA and axial involvement. Similarly, we would expect not only the subjective symptoms or the symptoms of the patients and the questionnaires, but also the imaging to improve. Here, 3 studies with a TNF blocker as a compound, one here with the IL-17 inhibitor. So all of them have shown significant improvement on the MRI images under treatment. And when we compare this data to what we know from Axial PSA, again, the only study that I can quote here, because that's the only one that examined that yet, at the moment, is the maximized trial. We've seen also here in the colored lines that inflammatory activity both in the spine and in the sacroiliac joint significantly improves under treatment, and those patients who were treated with placebo, when they switched to active drug, they also improved significantly. So in fact, also in PSA, when you examine the axial skeleton, you will see a significant, when patients suffer from symptoms, you will see significant improvement, not only from the symptoms, but also of the MRI activity. So I would like to summarize with this one slide, reminding you that there is a lot of more information than what just this scheme is showing. It is the entity of the disease, it is the clinical symptoms, it is the genetic background, it is the assessment of the disease we need more clarification on. It is, of course, that the treatments that we are having may be used in axial PSA as well, and it may be used not because we have nothing else there, but because it's also useful. The patients improve their clinical symptoms, the MRI is improving. What we certainly need is to understand exactly who is the patient who may have clear PSA, clear axial SPA, and maybe in a couple of years we will come up with a criteria of clear axial PSA to maybe also find the drugs that are most suitable to these patients and covering all aspects of what we call spondyloarthritis. And by that, I would like to end my presentation. Thank you very much, and I'm happy to take on questions.